Hey everybody, it's Kevin and it's Donna from RPH Ally. You'll notice that Donna is looking fantastic and tan, coming back from a vacation, which is wonderful. I'm so glad to be back with her. And she kind of threw a curveball toward me because hormones are a really interesting thing to talk about. And there's a lot of, I shouldn't say controversy, but different thought processes because of studies that we've encountered over the years on how important hormones are. Don and I are not going to talk about hormone replacement therapy necessarily inside of this, but really a review of why they're important for pharmacists and other healthcare providers to get a stronger hold on. And right after we run this reel, we'll jump right into it. Talk to you guys soon. All right, Donna, how are you? I've missed you. And you look fantastic. Are your hormones, you feel like they're all quite balanced from a nice
Never. Which is so important. We never talk about it, right? We never talk about this kind of stuff. Yeah. So when I saw that, the Endocrine Society had a scientific statement, I was like, hey, this is really important. And part of it is people are living longer and hormones are really changing no matter what our age is. So we really have to think about it for our older adults too.
Oh, so true. Yeah, I think, some recent studies that I came across, one of my colleagues sent me over a GPT that's a single cell GPT. So looking at what is happening on the cellular level in an RNA standpoint and us being able to map that in large language models so we can start learning more about ourselves. And a
Mhm.
big piece is really, regardless of what the RNA or the genetic material say, how are we responding? And one of those big responses is hormones. How are we releasing those hormones and how is our body being impacted? The other piece for me that's big, Donna, is just how are we seeing more and more technology utilization? And we act like the consumption of technology does not affect us physiologically, but we know that's not the case. And I think aging is a really good kind of segue of we are becoming more sedentary, staring at screens more often. And
Yeah.
sometimes that's also part of the aging process with that sedentary component. And it's not always just due to getting older in age and wanting to be in the rocking chair at
Yeah.
all.
Right.
It's really
Absolutely.
leads into your study that you were looking at.
Yeah. So, and what I just think is interesting is that, I remember when I first started out in pharmacy, and hormone replacement therapy was so big then.
Huge.
And I remember so many women asking me my opinion, and being the first female pharmacist at the pharmacy that I was working at also made them
Awesome.
want to speak with me and talk to me more about their medications and hormone replacement therapy. And I remember saying to them, this was like in the 1990s, and I said, you guys are really our guinea pigs. I'm sorry to say, like, we don't have a lot of information and long-term information and outcomes on this. So my generation is going to learn from your generation. And so we have. And women are living longer, men are living longer. We all, there's that trajectory that's going, but there's so many changes happening in our body, and they could really influence how we feel, and just how we function in general, maybe some other comorbidities. And also, do we treat or do we not treat? Because there's still a lot of questionable ideas out there. So I loved this actual scientific statement from the Endocrine Society, because it kind of updated everything that we can take right now while studies are still going on, and what to look for.
Oh, exciting. Because that's one thing when I was in pharmacy school, Donna, hormones were big in the other way. They were really big in the cardiovascular study that had come out, 15 years ago now, I guess, somewhere around there,
Yeah.
that really pushed everybody away from utilizing hormones because of worries of cardiovascular disease, breast cancer, et cetera. That has not
Absolutely.
been, let's maybe not say debunked, but it's been called into question how valid those things were in those studies. And so it's really exciting for you to give us some updates on where we are in the hormone thought process.
Yeah, Absolutely. So, so Kevin, I know like when we talked earlier, we're gonna talk a little bit about a couple of things and just some of the ideas that we have to be thinking about. And so when we're thinking about endocrinology, there's many different systems that we're looking at. And you have right now one of these that is from this actual statement. And this is part of the adrenal axis. And what I found so interesting on this diagram is you can see that if there's more aldosterone, then there's increased hypertension and cardiovascular disease. And that makes sense, right? If you think about the medications that we're using for blood pressure medications. So we can be looking at this and going, okay, this makes sense, increased blood pressure due to increased aldosterone. So those are ideas that we can be thinking about. The other part is the cortisol, which actually has a lot of um, impact on mood and memory and cognition. And those are things that we know that we've learned in so many um, ideas throughout social media and medical information is, oh, be careful of your cortisol, and you don't want that to be too increased with stress, etc., because it does have these effects. It of course affects your mood. It of course affects your cognition. If you're anxious or having issues, you're not thinking clearly, kind of thing. So we can see how cortisol has an impact on those ideas too. What I
Yes.
found wonderful about this in particular information is that they are saying that in aging, cortisol um, is attenuated, and so is an aldosterone. So just because of age, we are increasing these, and or they're not decreasing as we think. So many other things decrease in our systems as we age. I remember, my lecture in geriatrics many moons ago was a big arrow going down saying, okay, there's aging for you. So, but this doesn't. Cortisol and aldosterone do not necessarily reduce. They either stay the same or increased. And, and we can see that these are, excess of these are magnified in our aged population. So, we need to be thinking about how this affects people's blood pressures, how it affects people's memory, cognition, and mood. And it could be an imbalance that's occurring from this. So things to consider, right? When we're looking at patients and that are presenting with various issues. Maybe there's some hormonal imbalance instead of always thinking about, oh, we have to treat, this accordingly. Maybe we have to be looking at hormone levels too. I will say, first off, I am no expert in this area. This really intrigued me. And the reason why it intrigued me is the information that came out with this Endocrine Society scientific paper was basically that we all got to figure this out. We can't just be not talking about hormones. And if you think about our older adults right now, who are they? They're the silent generation, right? That's what we call them, the silent generation. They never talked about hormones ever. And so what would make them want to talk about hormones now? But and now we're seeing some more talk and more information, and people are becoming more on board with, even talking about menopause. There's years that women didn't talk about menopause even. So how are we talking more and more about this, and what are the things that we need to be considering, especially in our oldest old, who are the silent generation, and trying to help them understand that it could be hormones that are causing some issues, and when treatment might be appropriate and when treatment may not be appropriate. So I'd like to get into a little bit more of that too.
Yeah, Donna, I honestly, just your statement on what was pushed out, I definitely need to read deeper, because my thoughts on cortisol and aldosterone were exactly as you had previously described them, not as you just described them inside of this paper. It was always those decreased significantly, leading to these things, right?
Mhm.
And so in my mind, like there's a publication put out by the Mayo 3 years ago, something like that, and I'll show the graphic. So when I was thinking about hormones as a pharmacist,
Mhm.
and practicing pharmacist, like this was my thought process of
Yeah,
kind of working through things, and
of
I'll show
course.
the evidence here.
Yeah.
So really looking at, you have the effect of aging, which now, when we think about the effect of aging, Donna, it it isn't a necessity that the effect of aging is a given, right? Or just is a
Mhm,
conclusion. Sometimes the effect of aging is the effect of not eating well and not exercising, dieting, or sleeping well. Those things are all impacting hormonal flows just as well as just the number in your birthday. The next,
mhm,
I think, going down that graphic of the decline in anabolic hormones, habitual decline in physical activity, all those leading to obesity. And it's interesting that a lot of the hormones you and I are talking about and leading to, some are related to, the renin system and how we're manipulating fluids in our bodies, which,
mhm,
which is of course important. Other ones related to sexual hormones and libido or functionality or whatever the case may be, have a lot of study behind them and a lot of effort.
mhm,
But in a fascinating way, a lot of them are leading to one thing, which is very problematic, which is obesity. And that obesity, as you see in this graphic, is now what is being said to have a lot of issues around that. I don't necessarily think obesity is the best word, or phrase
mhm,
used here, especially when you're talking about, decreased muscle mass and increased adipose tissue, and really focusing on
mhm,
those things rather than just a BMI kind of strategy. But I'd love to hear, Donald, like after reading this endocrinology paper and jumping into it,
mhm.
is your mindset changed on how you're going to start evaluating hormones in your patients?
Absolutely. I think it's so intriguing, and I think with some of the things that are changing, like we've seen that hormone replacement, it was nixed, but there is a certain subset of folks that might benefit from that. We're going to get into that a little bit, but we also see this whole movement in low T, right? We've seen tons of commercials on low testosterone for men and what that actually means and what they're finding with that. Um,
Yes.
we also have to be thinking about thyroid, right? And we've talked about that before, but another hormone that we need to be thinking about. Um, we also have to be thinking about bone and osteoporosis. That's all hormone based as well. So when we are looking at these in how um, what are we treating? What's important for that patient? But what's that benefit versus risk? What other factors are we bothering or upsetting in the
Yes.
system that might show like, oh wait, this isn't a good option for this patient? So we need to be thinking about that. There have been some shifts with some products, and it's interesting to see this. Some are geographical even. So I really, encourage people to take a look at this whole program, this whole research statement, and really start thinking about, what's going on in your area. It can depend upon where you are practicing within the United States, within the world, and how you are approaching hormones and hormone replacement, and whether or not you're suggesting or not suggesting for folks.
So interesting.
Yeah.
Okay. What
Yeah. So if we can, let's get started with thinking about, first of all, we want to talk about the, excuse me, um, the ovarian axis. That's what we want to be talking about first. And as we know, we just talked about this previously. There was, such a huge use of hormone replacement, especially in the 90s. Um, it was used for women who were going through menopause to add the estrogen that was no longer being made or being decreased for the female. And they had to halt these studies, right? So it was out, and then they were doing these long term studies, and they're going, whoa. So when we were looking at the combined therapy of estrogen and progesterone, the combined therapy was halted after 5.6 years. Estrogen only therapy was halted at around 7.2 years. And it was because of this overall risk of stroke and other like heart attacks and pulmonary embolisms and emboli, excuse me, and other issues that were coming around that wasn't necessarily helping with the bone health for women. So it was, nixed that this is not appropriate for this actual um, therapy to help strengthen bones, and also to thinking about like hot flashes and cardiovascular health, thinking, oh, all these things were going to be improved, but in fact, they were not. So, but what they have found is that for the first 10 years of menopause, um, and if the woman is less than 60 years old, then it might be okay to do that hormone replacement. What they're finding is that in older women, or those that are 60 and older, and then they want to go on hormone replacement because they're still having hot flashes, or they're just like, having the continued effects of menopause, that is not ideal for women to start hormone replacement therapy or to continue. So we want to use it for a window of time and not just indefinitely. So when we see that, this is that whole deprescribing, we don't want to say no, but we want to optimize the medication. So does your patient actually fit into somebody who's pretty much cardiovascularly healthy,
Yes.
and not having already preconceived issues or cardiovascular disease in general? They certainly would not be a candidate. But when we can look at healthy women under the age of 60 that might benefit from hormone replacement therapy, it might be okay up until around that 60-ish age time frame. So something that needs to be constantly monitored and evaluated. So that was really interesting for me to be seeing and reading on. So they are still sticking to that. Yes, this isn't healthy for all women. It's not healthy for older women who are beyond 60 years of age. But there is a place in therapy for women to use this. They also say that lower dose and also the transdermal therapy is much safer than higher dose in oral therapy. So things to consider when you're thinking about, who's your patient and what might be recommended, especially if a patient at your counseling is having difficulty with menopause and menopause type of side effects. So there we go. There's just a little nutshell. And like I said, I am by no means an expert in this area, but these are the ideas that we're like, okay, this makes sense, and this is the research that's being done, and this is going to help me help my patients more so. And like I said, we don't talk a lot about hormones, and women might not be talking about their menopausal symptoms, especially our older adults that might still be suffering from this, or somebody is still on hormone replacement therapy. Is it still a safe product for them if they're in their 70s, 80s at this point?
So interesting, Donna. And I'm just like tearing through this paper right now as
Mhm.
you're speaking in these little bullet points. And
Yeah.
one thing that I love that they did is they started to address multiple societies in the way that they've interpreted guidelines over time. So, for example, they talked about the Women's Health Initiative and their limitation of
Mhm.
MHT for 3 to 5 years, and then compared that directly to the North American Menopause Society and the American College of Obstetricians and Gynecologists, saying that
Mhm.
there can be a larger duration. So, trying to summarize like everything that's been going on in the updates and then giving us some really interesting key points at the end of each one of these
Yes.
sections. And
Yes.
that the piece that I mean, that's going to stick in my head for the nugget is if you're within 10 years of that change and
Mhm.
less than 60, it
Yeah.
takes away from some of the complications. If those two things aren't true, then there's some additional detailing that has to be done for those patients. Okay.
Absolutely. Yeah. So I do, and I love those key points too, and this is what I'm highlighting as well as we go through. So the next is the testicular axis that we want to review, and this is a lot of the whole, the low T and all of these commercials, and I have to say too that if you think about um, consumers that are being targeted, they often say that older adults are targeted, and what do they target on? They target on, strength and libido and sexual activity, Alzheimer's. These are all things that they target because it makes people feel old when things aren't working properly, if you will, or their cognition isn't as good when they're having difficulty with their sexual relations.
Do-
So
Donna, have
this
you
can
ever heard
be
the commercials that it's like would you like to be smarter, faster, stronger, have more people like you? I mean,
Right, exactly.
that doesn't mean the answer is always the thing they're pushing. So,
Yeah, absolutely. So, people, the older adults are targeted, and they're often targeted because these are things that are happening with age, and we need to, kind of wait this out. But what I found was most interesting with, the testosterone replacement that they were suggesting is it's not very helpful. It is helpful for sexual activity, but beyond that, there is really no assistance or aid with cardiovascular is it isn't worse, but it isn't any better like you might think. Um, the strength and cognition and things such as that is not necessarily any better either. So there's no true benefit other than the whole sexual activity. But what was really interesting is they're finding that there's a very high, or I think high, increased risk of fracture for men who are treated with testosterone replacement. So
wow.
that was surprising to me to see, because you think stronger, right? And that this would be an issue. So anyways, thinking about that, and they were surprised by this. They didn't realize that this was going to be the case. So studies were very surprised by this outcome that when they were doing the Cochrane reviews, that
Yep.
Cochrane reviews, excuse me, that it was actually this this outcome that came about. So we need to be super careful about who we're providing this for, what they're hoping to what they're expecting from this. Why are they taking this? Are they taking it because they feel weak, or are they taking it for um, sexual needs,
Yep.
various things like that. So things to consider, and probably not all that we're hearing in the ads, like, oh, you're going to feel so much better and so much stronger, and have better cognition. That's probably not going to happen.
I'm curious here, Donna, when it comes to testosterone replacement, and I'll definitely jump through the study. When it was talking about the 65 plus, like that's where it really highlighted those things were not improving. For those
Mhm.
under 65 with hormone replacement, did it touch on that, like how younger generations of men are benefiting or not benefiting in this study?
I think it was all inclusive. There were a lot of there was a lot of 65 and older.
Okay.
Um, I am not 100% certain about that,
Okay.
Kevin, but thank you for
Well,
bringing that to my attention.
no,
Um,
I'll dig into it because I'm here's a
yeah,
couple
you.
curious points for you is that one, you're seeing more and more utilization of testosterone in younger men. And so I anecdotally I've heard of improved physical, components, which we've seen in the athletic world as well, right?
Mhm,
But one interesting kind of side note is I was talking to Richard Harris the other day, and him and I were talking about a very young patient he encountered that had a
mhm,
cardiovascular event related to him having a supplement of testosterone put on board, and his
mhm,
testosterone levels were not elevated, to begin with. Like
mhm,
they might have been slightly low, kind of
mhm,
deal. And so I think there's some interesting things. And one of the key points there was a large safety study is underway to evaluate the cardiovascular events during 5 years of daily testosterone versus placebo alone. And so I
mhm.
think there's a really interesting factor for us to hold on to, or is some of the risk factors that we may be missing out on too.
Right, right. So, just super important things to be considering. I'm not going to talk a lot about the thyroid axis because we've talked about this in the past, but there's that definite shift. And my take home point is don't treat unless the TSH is 7 or higher. So, I thought that was interesting because I think we're always trying to figure out when do we really treat. And it was typically, over 5, you is the kind of that window when you start considering, is the person symptomatic or not. But in our older adults, they're saying 7 is that point, and only if they're symptomatic at that point. So I liked that number had shifted towards the right,
Thank you.
and that we're not over treating low thyroid, hypothyroidism. So I really liked that. Um, Other things that I think was very interesting is even they talked about vitamin D in this, and all these things that we thought were so important for vitamin D. They're not necessarily seeing that it is super beneficial for cardiovascular, musculoskeletal purposes, cognition type things. They're not seeing that it is truly necessary. The only thing that they're finding with the bones is if it is actually combined with calcium. Um, so that was kind of one of the only true outcomes, if you will, for vitamin D. They do still say that vitamin D levels of greater than 30 is what would be key for people. So it is good to treat if they're under, but over that, you might not need to do so much vitamin D replacement.
Wow, that's super fascinating. I will definitely dig into
Yeah.
that. Did anything you want to touch on with the bisphosphonates in there, Donna? I see that they have a whole section on it.
Yeah, they certainly do. Actually, I wasn't necessarily going to get so involved with that, Kevin,
No, don't
but
worry.
it's something
Don't
that you're
worry at
seeing
all.
that
Just saw
you're
this.
suggesting.
Say it again.
Um, I said, is there something that you're seeing that that you wanted to talk about? I think with this, they talk a lot about what those levels are to treat, and what the T scores are. So I do think that we are concerned when the T score is less than -2.5. Definitely we should be treating,
Mhm.
but we need to, again, and we've talked about this previously, that's why I didn't get so much into it with the bisphosphonates, is um, we want to make certain that we're only treating within a certain amount of time frame in checking that and allowing for those holidays in between.
Love it. Love it.
So I just think that this was such an important paper that has come out. The Traverse study, which is all about the testosterone, is coming out pretty soon. So that I think these are things that we should all be looking at, and just trying to become more proficient in these areas, and thinking about our older adults, and are they still on these treatments, and is it appropriate for them or not? And we can use this as a wonderful guideline.
Yeah, I mean, honestly, Donna, it has me it has me questioning how updated I really am staying as I thought I was. Looking at this kind of in a global review,
Mhm.
which I love, because it's a good learning opportunity for our entire profession to get up to where we need to be.
Yeah.
The really interesting notes, like as I continue to scroll, Donna, were like, what's happening in diabetes? And I know that right now with the Diabetes Society that there is what was the recent publication, Donna? There's a big update though on the
Mhm.
way that we're performing and the way that we're taking care of our diabetic patients today as opposed to what was 5 to 10 years ago. And
Mhm.
some of those changes on A1Cs and oral glucose, treatments and everything else kind of related to it.
Yeah,
Some pretty massive updates. And I love that this paper is it's so comprehensive. Like it is really,
absolutely.
if you guys want to read something that is super interesting and already has me just like trying to rip through it as fast as I
Right,
can,
right.
that we will definitely put in the show notes for you guys.
Yeah, absolutely.
Wow. No, I love it, Don. Any other like final takeaways other than you giving me some nighttime reading
Right.
activity?
Well, one thing that they did say, and they're like, it's something that you really want to look at when you're looking at specific patients. So it could be that, there's this certain patient that you're curious about. And so use it as a guide for that. Don't, it, it's, there's a lot, it's such dense information that's in here that, it's going to take a little bit to go through, but definitely a worthwhile read. And like I said, I think enough to intrigue others to be thinking about um, some of the studies that are out there, what we have known for years, right? Or, you know, um, I think that so many of these things have become part of our conversations throughout the years, but I don't know if we're continuing to actually speak about them with our older adults. So, really optimizing those medicines as much as we possibly can and using this as a guide for them.
Wow. Yeah, I love it, and I think the only other things that I have done are just related to be able to take this kind of material and stay up with it. Unless you're doing it every single day, you have
Yeah.
to be able to pull some things away that you can highlight and then automate inside of your systems. And so if there are ways that you can look at these key points here, evaluate the data, of course, and look at it comprehensively and compare it to other studies
Mhm.
that are out there, of course.
Mhm.
But be able to pull these key points and then pull them into your electronic health record or your pharmacy management system so
Yeah.
that now you're getting triggers and flags related to the latest updates and guidelines. It's going to be huge for you to be able to stay on top of those things as you're starting to learn and progress with these updated guidelines. Because I think that's one thing that we forget too often is, we've learned something for so long, and the only way to make that transition is to have it literally come right into our face, so that we
Right.
know, oh, wait, you need to look at this.
Yeah,
Well,
for sure.
perfect, Donna. This has been illuminating like always, and I love your illuminated tan. I need to get this done myself and get that vitamin D level up, even if the studies are saying the
Well,
supplementation is there.
right. You take things naturally, right? And it works. It makes you feel good. So
So speaking of feel good, we got some really awesome things happening. Donna is doing more and more. She's got her book out there. So please make sure that you grab one of Donna's books here as soon as you can. If you're an RPHL member, you get a special discount there. And then also, Donna is speaking at our first ever soiree that is coming up way too quickly for me. We got all of our preparation happening in the background and getting all those things done, which we're really excited for. And if you guys want to know more about how to utilize your clinical knowledge, how to use your skill sets already today, not future of pharmacy 10 years from now, but what's future of pharmacy from present day to the next year to 2 years. We have a really incredible group of people talking, and I'm so thankful to have folks just like Donna that are experts throughout the country talking about what they're doing to really transform healthcare. So look forward to you guys coming there. We'll put the link in the show notes as well. Donna, any parting words for the audience?
just stay well and, let's keep learning together.
Love it. Have a good night, everybody.
Take
Bye-bye.
care, everyone.